This is a segment from my lecture on non-cardiac chest pain. I talk about two diagnoses, one easy to find, one a little more exotic. Let's take a look. So let's look at a couple of case studies. Here's our first one. This patient's short of breath and they have chest pain. They say it was sudden onset and that chest pain's just on one side. So what are we going to do? All your normal stuff, your EKG, which is negative, get your vital signs. On vital signs, maybe a little tachycardic, maybe breathing a little faster than normal, and their oxygen saturation is low. So what are we going to do with these folks? And I'm going to tailor this both to my EMS folks and also to my ER folks here. First thing you thought you have someone with a low saturation, they got something respiratory going on, you think, oh my, and this is a little mnemonic from one of my ER docs, and this will help you out. Oxygen, monitor, and IV. You can't go wrong with those in any critical patient there. For my EMS folks, definitely rapid transport. For my triage nurses, rapid transport back to a room for treatment. Physical exam, we'll talk about that in a little bit. And then for my nursing folks, these mnemonics from the EMS folks are really helpful. The sample history, signs and symptoms, A, do you have any allergies? M, for do you have any medications? Past medical history. L, last oral intake, just in case they might be going into surgery. And then E, events leading up to your symptoms there. And then for evaluating pain, especially chest pain, this OPQRST is very helpful. Onset, provocation, quality, crushing, stabbing, sharp, radiation, does it go up to your neck, shoulders, down to the tummy, severity, how bad is it on that 0 to 10 scale, and then time, how long has it been going on, has it changed, is it on, off, getting worse, all that kind of stuff. On exam, this patient has lung sounds that are diminished just on one side or absent on one side. And then your late sign on these patients, and this too late sign, is tracheal deviation. That trachea is being pulled to one side or the other. In the ER, they'll get a portable chest x-ray, and what we're going to see is this, tension pneumothorax. You can see, or maybe you can't, sometimes it's hard to see these x-rays on PowerPoints there, but good normal healthy lung tissue on this side. You can see the spidery vasculature of the lung there. On this side, you have basically a deflated balloon of lung tissue here. Here's a better schematic view of tension pneumothorax. This person's had some sort of problem with emphysema, cancer, tissue disorders, things like that, where there's a hole in that lung tissue and air is leaking out into the pleural space. And every breath gets more air leaking out, more compression of that lung tissue, and your whole mediastinum is pulled over away from that as that pressure builds up, and we're losing respiratory capacity there. Now it can be traumatic, so one risk factor for pneumothorax is a gunshot wound to the chest. We're really talking more of the medical ones here. And the closed pneumothorax. And we can talk about traumatic pneumothorax if I do a trauma lecture for you. Iatrogenic, that means hospital cause. So anyone who gets a central line put in, we got to get a chest x-ray on them to make sure we didn't cause a pneumothorax with that. And then more commonly in the environment, we're talking about spontaneous. I was just walking down the street and some problem in my lung caused that hole to just form up and we're losing respiratory capacity there. Emergent treatment for these folks, needle decompression. These are the folks who are really circling the drain and going downhill fast. If you have a little more time, your doc can put in a chest tube. Midclavicular line right in one of those top intercostal spaces. Gonna want to go right over the top of that rib there, and the lower margin of the ribs, you have nerve and vascular tissue. You don't want to start ripping apart there. Right over the top there, big 14 gauge needle, and get that chest decompressed, and you can go from there. So that was a fairly easy one. Now let's talk about zebras. And you ask, what do zebras have to do about this? And I thought this was a fairly well-known common expression until I started teaching this out. And people don't know this expression. This comes from medical school. You have interns who have had years and decades of book learning, and now they're going out with an attending, and they're having their first clinical experiences. And that attending is going to say two things to him. First thing he's going to say is, give me a medical student who only triples my workload and I'll kiss his feet. And the other thing is that they're going to say is, when you hear hoofbeats, think horses, don't think zebras. And what does that mean? That means Horses, let's take it in the real world. A patient has upper extremity pain. So an intern will look at him, come out, report to his attending, and what does he say? He's like, oh, he's got upper extremity pain. So what's your differential diagnosis? Well, he was in the Philippines in 1996, so I think he might have Hansen's disease. You mean leprosy? Yeah, could be. Or else maybe it's necrotizing fasciitis. Or maybe I saw this episode of Royal Pains where a guy had a parrot and he had some tropical disease from that, so it could be that. And the attending would say, well, those are all zebras. Let's think about the horses, the common things that might be like carpal tunnel or cellulitis. So that's horses and zebras. So in this lecture, talk about a bunch of horses, and now we're going to get into the zebras. Now, if you're living in a town of any size, your town probably has a zoo, and if your zoo is decent, it probably has a couple of zebras in it. So if you're driving this down the street and you see a zebra, well, it might be terribly uncommon, but it would not be out of the realm of the impossible if a zebra has escaped from your zoo. So these zebras that are out there, and I want you to give you the tools to recognize those when you see them. So our first zebra here is a chest pain patient with decreased level of consciousness. These patients present with a classic triad of symptoms. Have distended neck veins, hypotension, and muffled heart sounds. Now, anything ringing a bell from nursing school or paramedic school, very specific diagnostic triad, Beck's triad. I'm jiggling a few other keys there. This is a signal of cardiac tamponade. This is a buildup of fluid, typically blood leaking out of the heart into the pericardial space. Now your heart, when it's beating, in addition to that kind of squeezing beat, 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 also the way the muscles are striated, there's a lot of torque, a lot of twisting and turning involved. So to allow your heart to do that, there's usually a little bit of fluid, lubricating fluid, to allow the heart to bounce around and do that kind of stuff there. But if we have blood leaking out of a vessel, or even more catastrophically, a breach in the myocardium and blood leaking out of that, you're going to have some big problems. As that pericardial stack starts to fill up, it's going to squeeze the heart, so the heart isn't able to refill after each beat, and the greater pressure really brings your cardiac action to a standstill. So I want to do a real quick shout out for heart sounds here. Everybody has their thing. For example, when I was in my EMTB class, I had a preceptor who was a stickler for lung sounds. He'd say, listen to every lung sound you can. So I've got trouble breathing. Well, of course you're going to listen to lung sounds. I've got a headache. Well, listen to his lung sounds. I broke my finger. He wanted me to listen to lung sounds. Why did he want me to do this? So that you listen to every example of normal lung sounds you can on good days. So when your patient is having a bad day, you can recognize really bad lung sounds. If you're just listening to rails and wheezes and ronchi day in and day out, that's all you know, so you don't know good lung sounds. Same thing with heart sounds. Now, do I listen to heart sounds on every patient? No, I don't. When I have 6 patients and 14 in the waiting room and 3 ambulances coming in, I'm not going to listen to lung sounds. But when I got 3 patients, when I got a little time, I'm talking to them, I'm getting to know them, I'm going to listen to heart sounds. So now I have a good sense of this wide range of normal lung sounds in fairly stable patients. So when I have a bad patient, I can recognize bad murmurs, muffled heart sounds like we have in Beck's triad, and things like that. So this particular patient comes in very shocky, decreased level of consciousness. EKG is negative. This is an 82-year-old female. She had had an MI and had some stents placed earlier in the week. And then at home, she was complaining to her family of chest pain, collapsed and was brought in by EMS. Looked like kind of a heart failure picture maybe. Also, initially on presentation with this decreased level of consciousness, she was very restless. We couldn't get a decent set of vital signs on her. And I had known her from her first hospitalization. And I said, this is not that woman. She's not demented. She's sharp as a tack. This looks kind of neuro to me. So we ran her over to CT for a head CT. That was negative. By the time she came back, then her vital signs are really going down the tubes there. It looked like a heart failure picture. Going through the differential diagnosis, and my doc said, well, let's get an echocardiogram. Let's see how that heart's beating. So we did get that, and that's how we found that she was having this cardiac tamponade. What's our treatment for this? Pericardial stentesis. Now with our tension pneumothorax, I told you to jab a big needle into somebody's chest, and that may be a little bit of a chancy proposition in your book. Well, look at this one, where we take a big needle, shove it up under the xiphoid, aiming for the heart, hoping to get into that pericardial sac and aspirate that fluid out and get the heart beating again. Cardiologist was in very quickly to do this. When he came in to do this, he did this under the guidance of the echocardiogram, so he could see what he was doing there. He would aspirate that fluid, and when he did, it would just refill. So she just had a really catastrophic cardiac tamponade. How common is this? Maybe not so much of a zebra as we think. Here's a study from England where they're, for lack of a better term, a lot more autopsy happy than we are here in the United States. In the United States, at best, we have maybe a 10% autopsy rate in a lot of urban settings. In Europe and in England, they autopsy nearly everyone. They're just curious, why did this person die? Now here in the United States, you have an elderly person, they die, they just keel over. We call their primary care doctor and they say, yeah, I'll sign the death certificate. I don't know what they put on there. You know, keeled over and died, I don't know why, he was old, who cares? But there they want to know. And these studies found about 3% of their deaths had the proximate cause of death, the cardiac tamponade, or to use the very elegant British spelling, a hemopericardium. So I think a lot of our folks who come in cardiac arrest, presumed MI, may have some sort of tamponade involvement like this. Now I want to say that, let's just kind of take a breath here. I just want to say that we are in a very unusual profession. Every time you come on shift, you come into work, you put on your turnout gear or put on your scrubs. Every time you have that last cup of coffee and put on your stethoscope and walk out for your shift. We're in a profession where you could end up having the best day of your life, or you could actually save a life, and I don't know what happens, what that really means, because I don't know if I've ever really saved a life in my career here. You could help out a lot of people, make a few people feel better. How rare is that in the ER? Or it could be the worst night of your life. It could be you're watching somebody die right in front of you, you know exactly what's happening, and you can't do anything about it. With this patient, that's what was going on. And not only was this a patient that I had known from her previous hospitalization, it was my mother-in-law who was right there. You want to talk about a bad shift. That was the worst. But I got to say, she was a great woman. If there's a heaven, she's up there. And with my wife's permission, I always dedicate this presentation to her. So thanks for listening, and we'll continue on with our next case. Hi, if you liked what you heard here, I'm available to teach at your nursing conference, your EMS symposium, your fire department, your hospital, anywhere where healthcare professionals need continuing ed hours. My name is Curtis Olson. I'm an ER nurse and educator, and you can reach me at nursecurtis@windstream.net. Email me and I can send you a copy of my available lectures, any other details you need. Thanks for watching. Bye-bye.